Yes, like sorry for the delay, sir. Dr. Chandrasekhar, regarding today's moderator, Dr. Mukesh Sharma, is known a renowned neurologist practicing in Ahmedabad. He is need not to introduce he is very well known and well equipped with interventional neurology too. Sir, I would like to join this meeting. Sorry for the delay once more. Just today we were presenting two cases and what would be the um, pattern of management in these type of patients, like how we managed and how we could have been managed. So it's like I'm going to present two cases which happened for the last 2 to 3 months, happened between these 2 months. First case, when it comes to first case, 30-year female who brought with sudden onset of a headache followed by one episode of seizure and multiple bouts of vomiting. With this presentation, she came later day. However, when we have examined that patient and patient was drowsy, arousable, right-sided ptosis was there, and along with pupillary asymmetry and quadriparesis too. And she delivered a baby 20 days back through normal vaginal delivery. And this is about her past medical history, which is showing CT scan of on the first day, which is showing pre-pontine region. There is a hyperdense lesion with evidence of hyperdensity in between. And there is a hyperdensity in the fourth ventricle, along with sylvian fissure and perimesencephalic systems, along with the supracellular systems too. There is evidence of hydrocephalus also, as evident in bilateral temporal horn enlargement. With this background, and we had taken MRI. Just next slide, please. Yeah. This is how it was showing in an MRI, because we could not explain, or though we can explain regarding bilateral quadriparesis, and patient was having multiple infarcts in the occipital region and medial temporal region on the right side, along with posterior fossa too, which says she might be having thromboembolic phenomenon or vasospasm. And we further went on to the angiography. Can you forward? Just click on this. Is it playing? Yeah. Next one. One more click. This is right carotid angiogram, which was showing absolutely normal along with PCOM. Here is the PCOM. And when it comes to right side vertebral injection, there was an aneurysm, which is in the posterior circulation at the top of the basilar artery, and having an evidence of thrombosis. However, how much ever size we are seeing on the CT, and which is not correlating with the angiographic picture. Sir, in these scenarios, the patient is having partially thrombosed large aneurysm, which is approximately 1.5 centimeters in anteroposterior diameter, and height also is approximately 1.2 to 1.3 centimeters, 1.3 centimeters. And patient was having quadriparesis, and how we have to plan this patient management, sir. Sharma, sir.
Hello. Can you run again the basilar?
Basilar artery. It's just only, yeah.
Back. So it's MRI showing the large aneurysm, not partially, almost completely thrombosed.
Yes, sir. Yes, sir.
So it looks like that it's ruptures together is thrown the emboli also.
Yes,
probably. Sir. Okay, it's more of the occipital lobes. Okay, on the PC actually.
Yes, sir.
So definitely. So we
left
have
high
to
parietal, left high parietal is also there, sir. It's
yes.
cortex, motor cortex, and perimotor cortex. Left side also there is an impact on the hybridial region.
Yeah. So maybe because maybe went through the PCOM.
Sure. Yes, sir.
Okay. So we have to teach. So what are the modalities we have right now at
Yes.
present?
Yes, sir.
So treating like the surgery with this big aneurysm is very tricky. With- So surgery is option for these large aneurysms. I don't think any neurosurgeon is going to touch this. The second, we have the endovascular treatment. Okay. So uh, first, in this situation, we have to secure the aneurysm.
Yes, it's like how emergently we have to do is like, will it be possible? Because this is in a thrombosed aneurysm. Neck size, we are not sure. It's like whatever we are going to keep it. It depends upon the neck of the aneurysm. It's like how do we approach? Because like we are not sure about the neck of the aneurysm in this particular case.
Yeah, that's what I'm telling you. So how the thing is like if you are using the antiplatelet, okay, and placing the coil,
Yes, sir.
or if you're using the some stent or placing them some coil, is going to uh, refill again. Okay, so I preferred in this case like placing some coils. Now I know the size of aneurysm by MRI.
Yes, sir.
Okay, what is the size of aneurysm,
Sir.
and fill up that rest of the part slowly, and again repeat the NGO as early as possible. Okay, and to decide the further treatment.
Okay, sir. It's like here what we have thought is like next slide. Actually, it's like we had followed up the patient, and though it was a risky, next slide. Though it was a risky thing because being a ruptured aneurysm, we can't wait. There is a possibility for it to rupture again, but the patient was quadriplegic and having quadriparetic, not plegic, and having some financial issues, and we were trying to. By the time, at the same time, it's like as soon as possible, we have to secure the aneurysm. Though here the possibilities of having web and it's like a contour along with next end, though like, there was no definitive neck, so we had to size the contour as like next end web depending upon the size of the aneurysm, or otherwise like depending upon at least the neck of the aneurysm. So by taking the risk, and we have waited for till it clears the thrombus, and we have taken the follow-up images, and which was showing like on third day and after approximately 2 weeks later, and which was showing in parallel. The aneurysm opened up over a period of 3 weeks, and this is the last image which was showing aneurysm, which is totally opened up. Can you play it?
So I think this was a totally risky. Okay, whatever the penalized part of aneurysm, I would have put some coils. Okay, and allow more thrombosis should be happen there. Okay,
Yes.
so even in the next angiograph, if there is a like a forward pushing of the coils, there is always a space to place a intrasect device, or you would have done the stent assisted coiling also, because the result of stent assisted coiling and the putting some intrasect device is almost similar, a reocclusion rate. Okay, and third thing, like we have the intrasect device where we can put some coils also, like neck stent.
Yes, sir. Yes.
This from the same company, which is Contour actually.
Yes, sir.
Okay, that is preferred choice in this case where we want to place some coils in a stick than the Contour, because the Contour most of the time you don't want to place some coils, and it's more costly actually. I don't
Yes.
know what you did in this case.
Yes, it's like actually we thought that way because like whenever we are going to keep any sort of like next end, so if it is downsized, because like if the neck of the aneurysm we are sure, and this all depends upon the um, size of the neck. And if we oversize it, and then there won't be any problem. If we undersize it and there is a problem of migration of stent, migration of coils. So being we thought for that, and then it felt like risky, and we waited anyways, like by all my days, like we didn't had any rupture. And we went through this, like after seeing this scan, and third week of this follow patient scan, DSA, we felt like contour would be a better choice, because like now we can see the neck involving right PCA along with left PCA too. Can we go to the next slide, so that
So
like
have you placed some? Okay, sure.
yes, sir.
Yeah, go ahead.
Yeah, it's like this is the aneurysm which is showing right side PCA involvement along with the SCA also, and left side also. So there is a partial PCA except left SCA, and every vessel is involved in this particular case. And like neck is approximately, now we can see that 7.8, and width of the aneurysm around it's like 11.12, and height of the aneurysm around it's like 1.5. So with this scenario, can you go to the next slide? And we felt like placing of contour would be a better choice, because like next stent also we have to keep the coils, and if you are going for any other device, web also is not going to fit into that particular aneurysm, because like it would become heavy, and it might tilt to the any side. Stent assisted coiling also, we may have to give antiplatelets throughout, being she's an young patient, 30 years, and probably we just wanted to avoid the antiplatelets in this very young age if it is avoidable. In that scenario, we felt like contour would be a better option, because like we have to give antiplatelets only a part of time, not more than 6 months, as been advised in literature, so that we went along with the contour.
So you place the only contour without any coils?
Yeah, sir. It's like contour without any coils. If we are using neck stent, we have to keep the coils, sir. In contour, there is no need of coils, because it is a dense mesh. It is a
Yeah,
dense
so I
mesh,
totally
and it won't allow. It won't
so
allow. Yes.
so I have seen the complication where the neck is like the height of aneurysm is so large, like in your case.
Yes, sir.
Okay, somebody has placed the contour, okay, and contour flow actually in forward direction in the aneurysm.
Yes, sir.
Okay, it's become reverse. Okay, there's a reverse umbrella, it become the umbrella. Okay,
Yeah, yeah, sir.
and they have to place again some coil and then one more actually contour.
Yeah, yeah,
Okay,
sir. Yes, sir.
so you have to be careful because uh, there is a chances because there is a significant of flow is coming from the basal artery
Yes, sir.
and the contour may push forward.
Yes,
So
sir.
what you did for that?
Sir, actually, it's like in this, the good side of this one is like our aneurysm size is not more than the width of the aneurysm. Equatorial line or equatorial diameter of the aneurysm is not more than 14 mm. So in that particular, just you can, yes, this is the aneurysm where it is showing clear picture of involvement of multiple vessels. And we had placed the contour. You can see this tip of the contour. And in this also, it's like after placement of the contour, there is a stasis of the blood. It's like there is a good stasis of the blood, and there is no displacement of contour also. Can we come down? Next slide. Yeah, it's like this is how we have to see, sir, rather than neck. Neck is most important. At the same time, if the equatorial plane, depending upon the size of the contour, and if it is lesser than the contour size, and definitely we can place it. And as you told, the reversing of the contour can be prevented by oversizing beyond the equatorial diameter, sir. Here, the equatorial diameter was 11 mm, though neck was 7 to 8 mm. So here it was showing like neck size is 5 to 8, but the equatorial diameter is around 11 to 12 mm. So we have decided to place it a diameter of 14 contour size, which can prevent the forward migration and reversal of contour, and which can prevent the coiling placement also, sir. So that we have chosen the 14 diameter contour. It's like to the neck size approximately 7 to 10 has been prescribed by the company. We had placed this one, sir.
So you oversize the actually.
Yeah, sir. Yeah, sir. Yeah, sir. So that it snugly fits the side walls of the aneurysm, so that it prevents the reversal of this contour system, sir.
Okay.
It's like thereby we can usually it's like up to 9 diameter of the contour we can use O21 microcatheter, and beyond that we have to use the O27, so that we have used a neuroslider microcatheter, and we could place it without having any difficulty, sir. Prior to contour placement, we have to give antiplatelet, so that we have used antiplatelet before that, and later on we have reduced the dosage to 75 ecosprin, which we may have to continue at least 6 weeks to 6 months can extend, sir. This is about contour, and in next slide, this is almost the same neck stent as you told, and we have to keep the coils in this particular neck stent device, so that there is a like it is not a dense mesh, so that it allows the blood to enter into the aneurysm. So we have to place the coils in this device. Next. And this is like the microcatheter, regarding the microcatheter. Here 17 and 21 and 27, we have used Neuroslider 27, which will allow the maximum size of the contour, and which has a tip of one marker, like which is clearly visible, and where we can detach the contour without having any difficulty, sir. And when it comes to web, just wanted to go through the web also, so because why we have not used, I told, because if it is a slender one or a spherical one, we can use. The minimum criteria for web to use is like aneurysm should be more than 2 in size.
Both the device, there should not be any thrombus inside the user.
Yes, sir. After clearance only we have to keep, sir. That is where initially we could not place.
That is the first, yes, that is the first requisite.
Yes, sir.
Yeah.
In this also, it's like the minimum diameter of the aneurysm, as I told, it's like it should be more than 2 that is how it's been advised. It's like up to 7 we can use 4 to 7 diameter, and it's like up to 8 to 9. This is 8 to 9 diameter, and it's like beyond 9, 10, and 11. It's like, but maximum size we can go up to same as in contour only, sir. Only advantage and disadvantage what we can felt is web is bit heavy one. We have to see the architecture of the aneurysm, and if it is irregular, web becomes a difficult task. And if it is a regular aneurysm, which we can place easily, web. If it is irregular, and better to use contour rather than web. There is two generations, and SL and SLS webs. In these SL and SLS, approximately double layer one and single layer one, spherical one and cylindrical one. There is no much difference, but this is the one which cylindrical one, which we can place up to 3.5 to 4 diameter of the aneurysm, smallest aneurysm which we can place. As I told, in cylindrical one, we can go up to 3 sir, minimum size. Next.
Yeah.
Next slide. It's like, as I told, these are all the things and which we had mentioned, size of the aneurysm. And coming to the another case, sir, second case.
As I want to highlight the between the contour and wave. If there is some mismatch in when you are placing the contour, it's okay. Okay, it's not a such significant complication. But in the wave, you have to be like precisely do your framework, like sizing of aneurysm. That is very, very important.
Yes, sir.
Second, the deployment of the contour is easier than the wave.
Yes, sir.
Okay, I think it's the most easiest to place contour.
Yes, sir. Contour is like.
Yeah. So that is the one thing. Okay, please go ahead.
Yeah, thank you, sir. And it comes to the second case, in 40-year male who brought within a sudden onset of loss of consciousness while driving four-wheeler. And he had an episode of loss of consciousness, and post that he was having continuous headache. It's like he brought to the emergency, and where he was evaluated to have right Sylvian SAH, and which is showing here with a huge clot along with mild hydrocephalus. And this is the follow-up next day scan. After reaching our hospital, we did a repeated scan, and there is same amount of blood along with interventricular extension also with mild hydrocephalus is there, as evident in third ventricular dilation. With this, we had this is an angiography picture which was showing there is like irregularity in the bilateral ICA along with a supraclinoid aneurysm, which is approximately the choroidal region aneurysm was there. And the main purpose of presenting this case is patient is having a deranged or deformed arteries like bilateral ICA, and from the origin of ICA to intracranial ICA. So now when it comes to angiography, can you go to the next slide? It's like this is the picture of this patient, angiography, right carotid angiogram. Click on it. This is lateral view and anterior view. Here the patient.
Have you done the angiography of other arteries other than the brain in this patient?
No, sir. No, sir. It's like that is where
I think better to take the renal route also. Sometimes, like the patient who are having the fibromuscular dysplasia, they have the dysplasia of other arteries.
Yeah, sir.
Okay,
yeah,
the renal is the one of them.
Yeah, sir. It's like we had missed it, and actually, it's like here it is showing there is like a duplication of ICA or pseudo aneurysm. Yeah, it's like a dissection of ICA, which was doubtful because like there is a clear cut the gap between bilateral in a right ICA, and even when it comes to left ICA also. Yeah, it's like just again. Next slide. This is right side ICA and right vertebral artery. Next slide, left side ICA, left vertebral artery is there. This is left side. And both sides is definitely deformed arteries from the origin of ICA. And it's like later on, this is ICA. Can you stop there? Yeah. This is like there is no deformity in the ICA, sorry, common carotid artery, but carotid bulb also is looking normal. And beyond that only is like whatever the changes are happened in this particular cases. Bilateral ICA, deformation, or dysplastic artery with constriction and dilation and pseudoaneurysm formation on left side, and right side having two ICAs, whether it is a dissection or otherwise like is it duplication. Sir, can you comment on it, sir?
I'm not able to appreciate actually.
The previous slide. This is right side. So, sorry, this is left side and right side. Can you go to the above slide? It's like you can just click on it. Yeah, stop. In ICSR, like there is a gap, no, sir? In,
Where? Can you stop it? Where exactly you can see the two ICA?
Previous slide. Yeah.
Where is the two ICA?
Okay. It's not duplication, sir.
I'm not able to see that. Can you explain with the
it's like just point out it. There, yeah, that part. It's like there is a gap in that, and above also. It's like here also. Yeah, that part too.
Maybe dissection.
Okay.
So why duplication only at two parts? Maybe pseudoluminal.
Okay. Because like we are having differential diagnosis of both, sir, and along with.
Have you gone through the literature? Have you seen at this kind of the artery anywhere? Duplication?
No, sir. Nowhere.
No, it's a probably dissection, the pseudolumen formation probably.
Okay, okay.
And you had a bleed in the same artery, no?
Yeah, sir. Right side only, sir. There
So
is
it's
like so
probably
many.
probably a dissection at the multiple site because of the trauma. This has happened post-traumatic, no?
No, sir. It's like
No,
he.
no. Disease is pre-existing, but
Yeah, sir.
patient had the hemorrhage. Okay,
Yeah, sir. Yeah, sir.
okay. Yeah, it's not traumatic hemorrhage like that,
No, no, sir.
some
No, sir. It's like
SDH, a
he presented it
contusion.
only while driving. He had any loss of consciousness, but mild trauma. But though it was looking like, but we are not able to appreciate any acute process in this one. And see, when we see the CT scan, it is showing more of diffuse
Vascular
into.
injury, vascular injury, than the trauma related.
Mhm, yeah, sir. Yeah, sir.
Okay, so probably this has happened because of the dissection is may happen because of the trauma, and ultimately because of the dissection, patient had a bleed. Is it? Hello.
Yeah, sir. Yeah, sir. And here is like whatever the dissection we are seeing, is it a old one, sir? Because like hardly we have done the angiography in 2 3 days only, sir. Post event.
I think it's a dissection only, and there is a pseudolumen
Okay.
probably.
Because like when I went through the literature and both dissection and fibromuscular dysplasia
Hmm.
starts beyond the carotid bulb, sir.
So it is there.
It's like
You're
here
saying
though it is both sides. It is beyond that only, sir. The irregularities on the wall lumen both is there in the same region, but the only odd point towards the non-dissection is like fibromuscular dysplasia having aneurysms, like the protrusion in left side. When you see there is definitely a multiple aneurysms, which usually not evident in case of fibromuscular dysplasia. It's only produces like stenosis and dilation, though very rarely they have reported cervical aneurysms. In this, definitely we can appreciate the cervical ICA aneurysms.
yeah, we can appreciate not a one or two aneurysm like structures.
Yes, sir. Yeah. Next.
Okay, so
It's like this is the main crux of this, sir, because like right side there is dissection or duplication. Based on that, we planned for coiling this of supraclinoid aneurysm. It's like when it comes to how to calculate the size of the coil, sir. It's like how do we calculate? And when we went through the literature, and this is the maximum thing which we could get. Aneurysm volume equal to is like height into length into width into pi by 6, and coil volume should be around this. It's like we have to pack the aneurysm more than 30%. In that scenario,
at least 30%.
yes, sir. It's like this is how the calculation they had given. Usually, it's like in
Anybody is doing the calculation in India?
no, sir. It's like that is what I wanted to ask. Like, how do you approach? It's like how do you take the coil size, sir? Just wanted to ask
So
regarding.
takes coil size we usually like a width, okay,
Yes, sir.
and and the so we usually take the width and the height and ratio between the two. Okay, it's like if it is the width is 9 mm
Hmm.
and the height is a 7 mm. Okay, we
Hmm.
take usually 8 mm coil. Okay,
Okay. In between size.
in between size. Yeah.
Okay. Okay. So in this, we did like simple coiling, sir, with regular like an NY we have used along with microcatheter, and simple coiling we have done. The only way to present this case is like having dysplastic artery
So
and
so
having a
so you went through the which one, the right side one lumen or bigger lumen or the stenotic lumen, like we can see the two lumens, no?
it's like we went through this like a smaller lumen only, sir. Though we didn't preferentially go to that place, but whenever we are trying to go through that and we entered into the smaller lumen only, it's like the last one which was
Why?
showing.
Why I'm asking, because if it is a pseudo lumen,
Sir,
okay,
sir.
your catheter wire will not go to the aneurysm.
Okay, yeah, yeah. Okay, okay, sir. Okay, sir.
Okay, so that's why I'm asking you, okay, which lumen you went without any resistance, the smaller one or the larger one?
I was like it went through the smaller one only, sir, but we could reach without having any difficulty.
It means that smaller one is actually the true lumen.
Mm-hmm.
Even you can see the contrast, okay, darker in the smaller lumen, okay, more dark, okay,
Yes, sir. Yes, sir.
compared to the large lumen. Otherwise,
Yes, sir.
this should be opposite actually.
Mm-hmm.
Okay, so it suggests it's a, proper lumen,
Okay, it's like the smaller one is proper lumen and bigger one is like a dissected one.
probably. I think.
Thank you, sir. Thank you, sir. It's like and this is the only reasons. Like as you suggested, we had missed to get the renal shoot. There are two young patients which presented in a different way. One is like thrombosed large aneurysm. The other one is like dysplastic artery with aneurysms, like which might pose problems to any aneurysmal approach. So just wanted to get the experts' opinions.
I think you have gone through the fibromuscular dysplasia classifications
Yes,
or
yes,
the
like
disease.
yes, sir.
So
One, there were
just
three are there. One is like medial dysplasia, and second is intimal dysplasia, and third is like adventitial dysplasia, sir.
okay.
But
Okay, have you done anything for this dysplasia part of artery or not? No.
no, sir, nothing, sir. Because like the patient later on succumbed to it's like a massive edema of the brain. So we did decompressive craniectomy, and patient does like when he has reached and he was conscious obeying, but at the time of discharge, like he was deteriorated and like he stayed a long period in the hospital. It's like it was a stormy course. His GCS was poor, and it's like that's why, though we were planning supraclinoid, there is still dysplastic ICA beyond the aneurysm. So we wanted to place the flow diverter for that, because like to prevent further progression, at least intracranial part. It's like in to reconstruct the proximal part also, we were thinking how do we approach in proximal reconstruction of ICA, sir, if at all, if we wanted to do that. It's like
Covered
what,
stent.
sir?
Covered stent.
Covered stents, like multiple covered stents we may have to keep.
Yeah. That
Yeah.
is the cheapest and fine options.
uh, that's been planned, sir, but only thing is like his neurological status is now not very good, so we are waiting for his recovery, sir.
Okay. And second thing, whenever you do that, like some patient may need to place a stent, uh, no, never do a complete plastic because these arteries not having atherosclerotic plaque. So the whole lumen is having disease actually.
Yes.
So doing a proper angioplasty, that artery may dissect.
Mm.
So that is the one thing when if you are placing on stent in these arteries.
Okay. So it's like, how do we size, sir, in this? Like, definitely this is a dysplastic one, and one place it might be oversized, and one place it might be undersized. And how do
So
we?
you have to go to the normal artery up and down.
Okay, sir. So it's like we have to, in this particular case, we have to stand from common carotid to like almost Petrus ICA.
To the petrocyte. Yes. or slightly underside actually.
We have to take either proximal one or otherwise like distal one, which based on which diameter we have to take
The
the.
only thing is like if this dissecting artery is occluding and producing the recurrent ischemic stroke, and in that situation you can place a stent. Otherwise, these arteries doesn't require any stent, or you cannot place actually properly.
Yes.
And you should not, because there is always be chances of dissection in these patients.
Yes, it's like if there is multiple episodes of embolism or stroke, then only we have to place it.
Otherwise,
Yes, sir. Here says like one more to ask, like which one we have to choose, like which diameter, is a proximal diameter or distal diameter? Which one we have to take into the
so you have
consideration?
to go for the major diameter, no?
Okay, okay, sir. Okay, sir.
Otherwise, it will be mismatch. The stent is not going to open properly in that part. So stent is always be sized according to maximum diameter.
Okay, sir. Okay, sir.
Okay, even in the carotid, like we have the conical stent, but
Taper stents.
we have the tapered stent or conical stent or cylindrical stent. Okay,
Yes,
so if
sir.
you don't have the cylindrical stent, then you have to take the size of the common carotid artery, not the ICA.
Okay, okay, sir. Yes.
Okay.
No, no,
Anything else?
Jason, here, sir.
There are nice cases. Yeah,
Sir, one doubt.
please.
Sir, the bleeding chance is very less, na, sir, in this sort of dissecting aneurysm in the neck. No?
Yeah, bleeding, or where the blood is going to go.
Yeah, in the neck only. Yeah.
So it is not going to go in the knee. There is a muscle protection. The artery is going to bleed. It's nothing. It is not going to go anywhere.
Sir, every
So
time
if it is a rupture, why the CCF is happening? Because it's a pre-dura. Okay. So even you rupture in the cavernous part, or okay, there is no bleed. It's a fistula.
Yeah, extradural.
It's a fistula form. So it's extradural. The problem is when the artery is ruptured beyond ophthalmic in intradural part.
Yes.
Okay, even you rupture like doing angioplasty in the petrous part. Okay, sometimes it's rupture. Okay, when you are doing these are one like it's not uncommon site for the IC stenosis. Okay, the petrocavernous junction. So when you do the angioplasty, like putting a coronary stent, sometimes it's rupture. You can hardly see any bleeding. The problem is only when you say intracranial.
Sir, every time we see these sort of lesion, we have a stroke like on that particular side.
Petrocavernous?
Yeah, in few patients, like in between 30 to 40 years, we have seen 3 or 4 cases with these sort of lesions having stroke on the same side, artery to artery.
This fibromuscular dysplasia?
Unilateral.
Yeah, unilateral is common. It's not uncommon. So
Single
fibromuscular dysplasia, the focal fibromuscular dysplasia is the one of the classification where you can have a single artery is involved. Okay. So sometime like a generalized fibromuscular dysplasia, the where the multiple arteries involved. Like that's why in this case I asked for the renal arteries. Okay. So you can have that some aneurysmal dilatation in the renal arteries together. Okay. So the patient can have the single like one common carotid artery yeah, the carotid artery is involved in the fibromuscular dysplasia. That is also common.
And in one patient, sir, we had a stroke on on that particular side. Patient was having a dissection flap alone. And after medical management, repeat angio after 2 weeks was showing an aneurysm, dissecting aneurysm. That's it.
Okay. Okay. So dissection as such, we don't have the clear-cut data as what exactly should be done actually. Okay. So all the extracranial dissection by any region, the treatment is the antiplatelet, double antiplatelet or anticoagulation for a while, or maybe lifelong, later on the single antiplatelet. The most of the dissection they goes by itself. Okay, with the anticoagulation, antiplatelet. And even there is no recommendation which should be used actually, antiplatelet or anticoagulation. And if patient is having a recurrent stroke, then you should only treat with the stent or reconstruction of that artery.
So here one more question, sir. If it is iatrogenic dissection, because like these are all we are talking about spontaneous or traumatic dissections, which patient.
So you want to say while doing the procedure?
Yeah, sir. Yeah, sir. In that scenario, what we have to do is like just leave like that, or otherwise, like if the artery is not closing totally, just leave like that and keep on antiplatelet anyway will be start. Or otherwise, like stand it without taking any risk and go ahead with it. How do we approach regarding it?
So if the flap is not big, okay, if it is not moving, I think better to leave.
Okay.
Or if flap is big and moving, then better to place a stent.
Okay.
Okay, sometime what you do, just if your wire is there beyond the dissection, and you can balloon it. Okay, sometime what exactly happen, like when we are going up, like with the micro with the like guiding or long seat, we dissect the artery. Okay, not when we complete the procedure, because till then the artery is uh, sensitized with the, like, not accommodate the catheter properly, because the pneumodipin drip is going on and the artery is used to for that. Okay, so when we are going up, we usually dissect the artery. So uh, if the catheter is there, actually it's uh, it seal that dissection part. Okay, when you're coming out, if the flap is not moving, it's not increasing with the flow, I don't think just use the antiplatelet anticoagulation is sufficient, because it is healed actually strong. If flap is moving and the artery is getting occluded, then definitely better to place a stent.
Okay.
So what do you guys are doing in your center? You place a stent?
It's like till now we have not seen any dissections intra-procedurally, sir. So we had come across and we have not seen any like these type of cases, dissection with multiple embolism and all. So not sure about it, sir. So another question here, sir, it's like how much of time we have to wait, because like once it dissection happens, like if it is increasing, we have to place the stent, or otherwise like whether how much of time we have to wait, like fraction of
See, the
seconds.
flap is moving. Okay, with the angio, the arteries, the architect is different. Then better to place a stent.
Yeah, that.
Otherwise, wait for 20-25 minutes. If it is not moving, they stay in the same position. Okay, the contrast is not staying significantly going inside the flap, pseudo wall.
Pseudoaneurysm.
Yeah, pseudo wall. Yeah, aneurysm when it's dilate more, then it's okay. It is going to heal its own.
Okay.
If you have done the dissection in the aorta, no need to do anything, because when we are going up and we rupture the aneurysm aorta, actually in the opposite the direction of
it's like cerebral flow, and if it
yeah
any
yeah,
clot
but
goes
in
up,
the cell in the brain, It's in the direction of the flow.
Yes.
So if the size may increase, but it is in aorta